So if you look at the shaft of the humerus, it is closely related to all the nerves which are passing from the arm, that is the radial nerve, musculocutaneous, ulnar and the radial. Said that it is closest related to the radial nerve, which is just at the back of the mid shaft of the humerus, what you call it is a spiral groove. And once it crosses the spiral groove, it comes at the lateral edge where it pierces the lateral intermuscular septum. So once it crosses the spiral groove, which is behind here, it pierces the septum, which is here, then it comes in front of the septum. And that's where it actually starts coming very closely related to the lower third of humerus, which we will discuss in the Holstein Lewis. Brachial artery right in the front here. Between the brachial artery, you have got the brachialis muscle, so it's well protected, not very commonly injured, but yes, it can occasionally. So with respect to the radial nerve, remember that the mid shaft humerus fractures could result in the radial nerve injury in the spiral groove. Spiral groove is the groove behind the shaft of the humerus in the middle third. And lower third spiral or oblique fractures, which we call it as Holstein Lewis fracture, can result in radial nerve injury also. There are various muscles supplied by the radial nerve, which is important for you to read yourself, because that's how you can explain that when the nerve is injured in the axilla, or nerve is injured before the groove, nerve is injured in the groove, nerve is injured here, or nerve is injured after it crosses the elbow joint. From there onwards, the radial nerve is called as posterior interosseous nerve. So once you know at what level which muscle is supplied, it becomes easy for you to figure out the clinical features. So above the groove, just above the groove, the radial nerve supplies the triceps. In the groove, it also supplies the medial head of the triceps. It means that by the time it has entered the groove, it has already supplied the triceps. It means that if the radial nerve is injured in the spiral groove, the triceps function will not be hampered because it is already being supplied before it entered the groove. Once it crosses the septum and comes in the front, it supplies the brachioradialis, this is brachioradialis, and extensor carpi radialis longus. Means extensor means extension, carpi means wrist, radialis means on the radial side, and longus means longer of the two. Its main function is extensor carpi, means I extend the wrist. So over the border it supplies this, and once it crosses the elbow, by the time it enters into the supinator, from there onwards it is known as posterior interosseous, that is I have written as PIN, posterior interosseous nerve. From there onwards it will supply the ECRB, that is extensor carpi radialis brevis, supinator and all other extensors which are attached onto the lateral epicondyle. It means if the radial nerve is injured here, just above the elbow, patient will have wrist drop and the finger drop. But if the radial nerve is injured, as it is known as posterior interosseous nerve, patient will not have a wrist drop, because by that time ECRL, that is extensor carpi radialis brevis longus, would have escaped the injury. So patient will retain the wrist extension but will have only the finger and the thumb drop. How it is injured? It can happen with the direct injuries or fall on the outstretched hand, and when that happens, sometimes if the limb rotates, you can have a spiral fractures or sometimes an oblique fracture. Sometimes there may not be anything on the skin, or occasionally you may find an ecchymosis onto the skin, but patient will have pain, swelling and deformity over the arm, and patient will find difficulty in moving elbow and the shoulder because it creates a lever between the two joints. So patient will find difficulty in moving elbow as well as the shoulder. The signs will be, there will be bony tenderness over the humerus. You may also find the crepitus and abnormal mobility. Crepitus and abnormal mobility are not usually assessed, but yes, they are part of the fracture signs. Always assess the vascularity of the limb, and when there is a fracture of the shaft of humerus, it is important that one must look for the injury to the radial nerve. if the shaft humerus is fractured, usually the radial nerve is injured in the spiral groove, which is an MCQ for you. Patient will lose all the function of the brachioradialis, ECRL, ECRB and all extensor. So patient will have a wrist and finger drop, hand will be like this. Patient will also have loss of sensation in the first dorsal web space. This is where is the autonomous zone of the radial nerve exists. How do we confirm the diagnosis? Just a simple plain X-ray, AP and lateral view of the arm. We do not require CT because it's a diaphyseal fracture. How do we treat? Remember, more than 90 to 95% fractures of the shaft humerus can unite with conservative treatment like clavicle. And what do? We just reduce it and give a U cast or a hanging cast. I'll show a picture for that for 6 weeks, followed by FCB means functional cast bracing. FCB is functional cast bracing. So 6 weeks, 4 to 6 weeks you can give a cast and followed by another 6 to 8 weeks you can give a functional cast bracing.